Foundations of Maternal-Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones, 7th edition. Chapter 11, The Childbearing Family with Special Needs. All families must make major changes as they adapt to pregnancy and childbirth. For some families, however, changes are particularly difficult. Such families have special needs related to parental age, substance abuse, birth of an infant with congenital abnormalities, perinatal loss, adoption, or mental health disorder. Perinatal nurses can make a difference in the lives of these families. Adolescent pregnancy. The 2015 birth rate to teenage mothers, age 15 to 19 years, in the United States was 22.3 per 1,000 teenage women. 229,715 babies were born to teenage mothers, decreasing 8% from 2014. This continues to decline from 1991, when the rate was 61.8 per 1,000 teenage women. The reasons for the decline are not totally understood. However, the evidence suggests abstinence rates are increasing among teenage women, and those who are sexually active are more likely to use contraceptives. Although the decline is encouraging, teenage pregnancy rates in the US are still substantially higher than in other Western countries, and there are significant racial disparities. The teenage birth rate was the highest, 34.9 per 1,000, among Hispanic women, followed by non-Hispanic Black women, 31.8 per 1,000. American Indian Alaska Native women, 25.7 per 1,000. Non-Hispanic white women, 16 per 1,000. And Asian Pacific Islander women, 6.9 per 1,000. Factors associated with teenage pregnancy. Many factors may contribute to one becoming a teenage mother. The U.S. Department of Health and Human Services recognizes those teens who are homeless in the juvenile justice system and in the foster care system as most at risk for teenage pregnancy. Adolescents tend to engage in more frequent high-risk sexual behaviors because there may be a lack of consideration of the consequences that accompany their actions. Many adolescents believe teenage pregnancy will never happen to them. Increased abstinence, education, and more effective contraceptive practices have assisted in the recent decline of teenage pregnancies. Some adolescents chance pregnancy and parenthood as a means of maintaining a relationship and/or having someone to love them, whereas others see it as a means to gain independence. Factors that contribute to teenage pregnancy are listed in box 11.1. Sex education. Sex education for teens should focus on helping them clarify their own values and beliefs regarding sexual behavior. Recognizing consequences associated with risky sexual behaviors, understand how to set appropriate boundaries regarding their own sexual behaviors, and learn effective measures to prevent pregnancy and sexually transmitted disease, STD. It is especially important that teens learn the importance of setting limits on sexual behavior and are equipped with the tools to know how to say, not now, not yet, and not you. Many teenagers may find themselves feeling pressured by peers into engaging in sexual activities when they lack the emotional maturity to deal responsibly with intercourse, contraception, or an unplanned pregnancy. When providing sex education, nurses should keep in mind that adolescent males and females mature at different rates and may be more comfortable learning and discussing topics in separate groups. In talking with teenagers, nurses should use simple but correct language such as uterus, testicles, penis, and vagina. Socioeconomic implications. Teenage pregnancy can prove to be an economic burden because often the teen is still in school and unable to work and make enough money to sufficiently provide for the child. Often, it is necessary for the teen to receive government assistance to have the basic resources needed to provide food and shelter. Categorically, teenage parents cost U.S. taxpayers millions annually through government programs, the foster care system, and the legal system. Teenage parents are less likely than their childless peers to finish high school and go to college, more likely to live in poverty, and more likely to depend on government assistance. The financial cost of teenage pregnancy is huge. There's also a psychosocial cost to the teen and a cost to society. The developmental tasks of adolescence, such as achieving independence from parents and establishing a lifestyle that is personally satisfying, may be interrupted when a pregnancy increases the need for financial and emotional support from parents. Table 11.1. Instead of becoming independent, they often become more dependent on their parents or their boyfriends because of pregnancy. Education goals may be curtailed for some young mothers, limiting employment opportunities and resulting in reliance on the welfare system. Positive outcomes from the pregnancy also may occur. For some adolescents, pregnancy provides them with a motivation to further their education and provide a better life for their child. Pregnancy and birth may have a stabilizing and maturing effect on adolescents who use the experience as an opportunity to change past poor lifestyle choices and become more goal directed. Implications for maternal health. Compared to older women, teenage mothers have an increased chance of perinatal complications, including death, pregnancy associated hypertension, anemia, preterm labor and birth, depression, substance abuse, intimate partner violence, poor nutrition and self care, perennial lacerations, and striae gravidarum with itching. Teenage mothers may delay seeking prenatal care and delay finding and receiving postpartum care and care for their newborn. The lack of maturity and reasoning that often accompanies adolescence makes teenagers less likely to properly use reliable methods of birth control, increasing their risk for another pregnancy. Figure 11.1. Statistics reveal that those who have had one teenage pregnancy have a 23% chance of having a second teenage pregnancy. Some women may panic at the thought of an unplanned pregnancy and choose to have an abortion. The decision to abort can bring conflicting feelings of sadness, guilt, and relief, and be difficult for the teenager to process. Implications for fetal and neonatal health. Infants born to teenage mothers have a higher risk for preterm birth and low birth weight. Infants of teenage mothers tend to have lower APGAR scores at birth and experience higher rates of neonatal death. The teenage expectant father. The majority of teenage mothers have partners who are within 2 years of their age, but some may have partners who are older. These men may accept responsibility for the child, or they may become phantom fathers who are absent and rarely involved in raising the child. Almost all adolescent expectant fathers indicate that they are not ready for fatherhood. Many are depressed as they grapple with the conflicting roles of adolescence and fatherhood. Although some express interest in learning about childbirth and child care, those who do not want to be fathers are less likely to be supportive. Some do not wish to be involved in the child's life, leaving the young pregnant woman to seek support elsewhere. Other fathers are involved to some degree during the pregnancy and early years of the child's life, but become less involved over time. Many adolescent mothers perceive that support from their partners is inadequate. A disproportionate number of teenage expectant fathers are from environments of poverty and lack job skills or educational preparation. Many need job training before they can earn enough money to contribute to the support of their children. To help provide financial support, the father may have to interrupt his education to find a job. Impact of teenage pregnancy on parenting. Evidence shows that 82% of teenage pregnancies are unintended. This unexpected and unwanted life event can lead to difficulties in the mother establishing a bond with her child and embracing the new role as parent. Teenage parents are still growing and developing a sense of self and often do not possess the maturity or patience to parent well, and thus children born to teenage mothers are at greater risk for abuse and cognitive delays. Teenage parents often need substantial resources to adequately provide for their children. Community resources such as parenting classes, as well as self help and career classes, are beneficial in preparing teenage parents to assume new roles and prepare to meet the physical and emotional needs of their child. Application of the nursing process, the pregnant teenager. Assessment, physical assessment. Assessment of pregnant teenagers is like that of older women in many respects. At the initial visit, obtain a thorough health and family history to determine whether conditions such as diabetes or infectious diseases increase the risks for mother and the fetus. Monitor closely for signs of iron deficiency anemia, preeclampsia, or STDs. Attempt to identify behavioral risk factors such as poor nutrition, smoking, alcohol or drug use, or unprotected sex, which could harm the mother or the fetus. Screen for physical or sexual abuse, which is more common in pregnant teenagers. Teenagers are sometimes defensive and inconsistent in their responses because they may not volunteer information about nutrition, exercise, and the use of alcohol or other drugs. The nurse needs to press for details. The teenager's statement, "I eat okay and I'm pretty active," requires follow up questions worded to obtain specific information. What foods do you especially like? What did you eat yesterday? What kind of things do you like to do? Structure the interview so questions can be interspersed in a more general conversation that explores the teenager's likes and concerns. For example, questions such as, "Will you be able to continue the swim team after the baby is born?" may help the nurse establish rapport, gain a better understanding of the teenager, and determine whether she is making plans for the future. Cognitive development. Determine the teenager's level of cognitive development and ability to absorb health counseling. The three most important areas of cognitive development are as follows: 1. Egocentrism, interest centered on the self, which involves the ability to defer personal satisfaction to respond to the needs of the infant. What will you do when the baby gets sick? How will you help the baby get better? 2. Present future orientation, which involves the ability to make long term plans. What are your plans for finishing high school? What will you and the infant need in the first year of the infant's life? 3. Abstract thinking, which involves identifying cause and effect. Why is it so important to keep clinic appointments? Why should condoms be used during sex even though you're pregnant? Knowledge of infant needs. Assess knowledge of infant needs and parenting skills. How does a teenager plan to feed the infant? Nurses should encourage breastfeeding. See Chapter 22. What will she do when the infant cries? How will she know when the infant is ill and should be taken to a pediatrician? Does she know how much the infant should sleep? What plans have been made to provide for the safety needs of the infant? Family assessment. Begin assessment of the family unit by determining the degree of participation by the father of the infant. The father may deny responsibility for the pregnancy, be married to or plan to marry the expectant mother, participate in the pregnancy and rearing of the child without marriage, or be totally uninvolved. Assessing the adolescent without the presence of her parents is important, yet it is crucial to determine the availability and amount of family support. Will the pregnant teenager live with her parents? How do her parents feel about the pregnancy? How will they incorporate the mother and her infant into the family? Families generally respond in one of the following three ways. 1. A family member, often the adolescent's mother, assumes the mothering role, which the teenager may abdicate willingly. 2. All care and responsibilities are left to the adolescent mother, although shelter and food are provided. 3. The family shares care and responsibilities, which allows the teenager to grow in the mothering role while completing the developmental tasks of adolescence. It is particularly important to assess the perceptions of the pregnant teenager's mother. How does she feel about becoming a grandmother? Many women feel embarrassed and disgraced. She may feel that she has failed as a mother, or she may resent the new cycle of childcare in which the pregnancy involves her. Is communication with her daughter open? Is she aware of the difficult role conflict as adolescent and mother that her daughter will experience? Many pregnant adolescents live with their mothers, who provide various levels of support. If the family is unable or unwilling to provide care for an adolescent with an infant, what other social support can be identified? In some situations, the family of the baby's father may be of assistance. Identification of patient problems. Many adolescents wait until the second or third trimester to seek prenatal care because they either do not realize they are pregnant, continue to deny they are pregnant, or want to hide the pregnancy. They may not know where to go for care and may fear the effects of pregnancy on their lives and relationships. In addition, many teenagers have little information about physiologic demands, such as the increased need for nutrients that pregnancy imposes on their bodies. As a result, they may have a pattern of sporadic prenatal care and missed appointments. Many adolescents are unaware of ways to promote health during pregnancy and therefore need health teaching. Increased family stress as a result of inadequate coping strategies is another common problem. Planning expected outcomes. The expected outcomes for the need for health teaching are as follows. 1. The expectant mother will keep prenatal appointments and follow healthcare instructions throughout pregnancy. 2. She will communicate her concerns throughout pregnancy and participate in learning about infant care. 3. The family will verbalize emotions and concerns and maintain functional support of the expectant mother and her infant. Interventions. Eliminating barriers to healthcare. The two major barriers to healthcare are 1. Scheduling conflicts, and 2. Negative attitudes of some healthcare workers. Help the adolescent locate the clinic closest to her that offers appointments when she and her partner, if they wish, is available. Provide information about public transportation to that location if necessary. Some clinics are open in the evening or on Saturday. Communicating with adolescents requires special skills. Nurses should match their teaching with the teenager's cognitive development. Those who are 15 years old or younger need concrete explanations because their ability to understand abstract reasoning is not yet developed. Nurses should avoid seeming authoritarian because teens may see this behavior as interfering with their independence and may not return for care. When nurses work with adolescents as partners in care, adolescents are more likely to follow nursing recommendations. Applying teaching and learning principles. The lives of adolescents change greatly during pregnancy and even more after the infant is born. They often feel isolated from peers who may not understand the responsibilities of parenthood. They no longer may be able to participate in activities with their friends because of childcare obligations. Teens often are hesitant to ask questions, discuss concerns that are common to pregnant adolescents, and ask the pregnant teenager if she has other questions. Because peers are important to adolescents, arrange for them to participate in small groups with common concerns. Being with peers may make her feel more comfortable in asking questions and voicing concerns. Specific needs that might be addressed are the benefits of prenatal care or help in eliminating unhealthy habits such as smoking, drug use, or alcohol consumption. Find common goals that may be discussed in groups in which the teens can assist each other to have a healthier pregnancy. As pregnancy progresses, needs and group focus change and preparation for labor and delivery and infant care become priorities. Repetition is an important method of teaching and clarifying misinformation. Allow ample time for discussions. Although teenagers often do not read or benefit from printed materials to the same degree that older patients do, material that is prepared with adolescents in mind may be helpful. Information regarding reliable internet sites may be well received. Teens often respond well to audiovisual aids. Numerous well made videos are available that deal with all aspects of prenatal and infant care. It is particularly important that the nurse does not sound like a parent when working with adolescents. Avoid using the words should and ought, offering unwanted advice and making decisions for the teenagers. Maintain an open, friendly posture and convey empathy by using attending behaviors such as eye contact, frequent nodding, and leaning toward the speaker. Box 11.2 summarizes additional recommended methods for teaching adolescents. Counseling. Allow time to counsel teenagers about their specific concerns, such as nutrition, stress reduction, and infant care. Nutrition. Nutrition counseling is one way to help reduce the incidence of low birth weight infants. Determine the adolescent's general nutritional status and assess for eating disorders that would reduce caloric intake and possibly affect fetal growth. Emphasize that she is still growing and her intake should be adequate for her own growth as well as that of the fetus. Ask if she prepares her own meals, if someone else prepares them, or if she eats away from home for most meals. Discuss nutrition during lactation, pointing out the advantages for both mother and baby. Tailor information to suit the individual adolescent's likes and peer group habits. Teach her how to prepare simple meals and how to make the most nutritious selection from fast food menus or select and plan for healthy snacks when she is away from home. See Chapter 8. Nutrition education should be socially and culturally appropriate. Refer the teen to food stamp providers, the Special Supplemental Food Program for Women, Infants, and Children, WIC, surplus food distributors, and food banks if necessary. Many teenagers have limited access to food and lack the ability to store or prepare it. Self-care. Provide the same teaching about self-care that would be given to an older woman. In addition, emphasize the importance of using a condom for prevention of STDs, even though she is pregnant. Counsel the adolescent about lifestyle changes, such as cessation of smoking or substance abuse, which will benefit her and the fetus, and refer her to resources that offer help with these problems. Stress reduction. Identify the stressors in the adolescent's life. Stress may be related to basic needs such as food, shelter, and healthcare. Fear of labor and delivery and fear of being single, alone, and unsupported all create stress. The developmental tasks of adolescents while working on the tasks of pregnancy is another stressor. A variety of measures may be used to reduce stress, depending on the teenager's age, situation, and available support. Refer adolescents with chronic life stress to a social worker for help to achieve stability. If the girl is very young, or if the pregnancy is a result of rape or incest, social services and law enforcement agencies should become involved to provide protection and assistance. The pregnant teenager often experiences stress because she has not told her parents or the father of the infant about the pregnancy. Explore her reluctance to do this and role play the encounter with her to help her work out a plan for breaking the news. Although there is strain on the relationship when the teen first tells her parents, their relationship may improve over time if her parents are supportive. If appropriate, encourage her to tell the expectant father so that he can work out his role. Teens who experience high levels of stress during pregnancy and the postpartum period may spend less time on infant care activities, feel less competent as parents, and have a more difficult time adjusting to being mothers compared with teens with lower levels of stress during pregnancy and postpartum. Therefore, interventions to reduce stress in pregnant adolescents have an impact on the infant as well as the mother. Help the teen think ahead to how her life will change because of the pregnancy and what may interfere with the mother role. Help her identify possible solutions to the problems presented. Assistance with resolving conflict with support persons and identifying new sources of support are other important interventions. Attachment to the fetus. Because attachment begins during pregnancy, helping the adolescent begin this process is important. Seeing the fetus move during an ultrasound often changes any pregnant woman's perceptions about the fetus. Hearing the fetal heartbeat and feeling the baby move may increase attachment. Looking at illustrations of the fetus at different gestational ages increases the mother's interest. A heightened awareness of the fetus may make her more likely to follow suggestions that will enhance fetal well being. Discussion of the fetal changes month to month may lead to discussion of the capabilities and needs of the neonate. Infant care. The priorities for teaching gradually change from maternal needs to infant needs, with emphasis on infant care and normal growth and development. Discuss common early developmental changes to help the young mother understand the normal progression of infant abilities. Explain and demonstrate infant cues using behaviors of the infants in videos or in the group as examples. In terms of gaze, vocalization, facial expression, body position, and limb movement. Describe the way infants use these behaviors to talk without words and ways in which parents can use the behaviors to respond to their infants. Emphasize that eye contact, holding, cuddling, and verbal stimulation are important for the child's development. Because adolescents tend to have a more rigid and punitive approach to childcare, explain that infants develop a sense of trust when their needs are met promptly and gently. In addition, their future development depends on attaining a sense of trust during infancy. Emphasize that crying does not indicate that the infant is spoiled, but simply that the infant has a need for food, warmth, or comfort and love. If a support person will be involved in helping care for the infant, include that person in teaching, especially if the support person has limited experience with babies. Having a support person learn with her may help the teenager remember the information better. Breastfeeding. Adolescents who decide to breastfeed their infants need support in their endeavor. They should be praised for their decision to do what is best for the baby. Adapt teaching to the mother's level of understanding. Encourage questions because the young mother may have much misinformation. Privacy is important to adolescents. They often feel embarrassed to breastfeed in front of others. Provide help with correct positioning and latching on of the infant. Show her how to drape a blanket to cover her breast and the nursing infant. Check on the mother frequently during feedings to identify any problems and intervene appropriately and in a timely manner. Discuss problems that may occur so she has a realistic understanding of them and knows when and where to seek help if necessary. Offer praise liberally. Success in the baby latching on to the breast and seeing the infant gain weight may be very rewarding for the mother. Promoting family support. The pregnant teenager needs encouragement to include her family in her decision making and problem solving. The involvement of her mother, older sister, or other close relative is particularly important in terms of future plans. Discuss topics such as who will care for the infant, whether the teenager will return to school, and what financial assistance is available from the family and the infant's father. Adolescent mothers who have adequate emotional support are more likely to learn appropriate parenting techniques. However, if the family has multiple problems such as substance abuse or family violence, Involving them may be inappropriate. In such situations, the teenager should be encouraged to communicate instead with a family friend or another trusted adult. Providing support during labor. The needs of pregnant adolescents during labor are similar to those of the older woman. Support at this time is especially important in helping them feel safe and cared for so they can have a successful childbirth experience. Providing referrals. Make referrals to conveniently located national and community resources for pregnant adolescents. Include well baby clinics offered by the Public Health Service and assistance programs offered by state social service agencies. Church and community organizations also may provide needed assistance. Childbirth education classes specifically for teenagers are often available. Programs for school-age mothers are offered by many school districts and provide an opportunity to complete high school education and take the much-needed classes in childbearing and parenting. Some schools include pregnant adolescents in regular classes and add other classes to meet their special needs. Evaluation. Nursing care has been effective if the pregnant adolescent keeps prenatal appointments and participates actively in her plan of care, as demonstrated by asking questions, sharing concerns, and adhering to the recommended program of care. She should demonstrate basic knowledge of the infant's needs and care of the infant. Family support should be available, but if it's not, referrals to agencies that can provide assistance should be made. Delayed pregnancy. It has become increasingly common for women to delay childbearing to further their careers, marry later, or establish financial security. However, delaying childbearing is not without risk. With advanced maternal age comes an increased risk for infertility. Although advances in contraception and fertility management have provided options to women who choose to delay childbearing and the ability to still conceive, there are physical and financial constraints they may face. A woman's fertility begins to decline at 32 years of age, with the most significant decrease taking place at around 37 years of age. Maternal and fetal implications. Some of the risks associated with advanced maternal age, aside from infertility, include miscarriage, multiple gestations, and chromosome disorders such as Down syndrome and aneuploidy. Older mothers are also at increased risk for pre-existing chronic conditions such as hypertension, diabetes, and uterine myomas, fibroids. One should also consider the psychological implications that may come with infertility struggles. Women may experience a wide array of emotions such as depression, anxiety, and guilt for delaying childbearing. Advantages of delayed childbirth. Some significant advantages also are found with the delayed childbirth. Patients who have delayed childbirth tend to be more mature and of higher education and socioeconomic status. These traits result in them often being better equipped to deal with the emotional and financial demands of parenthood. Figure 11.2. Nursing considerations. All women of advanced maternal age, older than 35 years at estimated day of birth, should receive honest and clear preconception education so a plan can be identified with their healthcare provider before trying to conceive. Chronic conditions should be treated before conception. Women should be counseled on all diagnostic tests available to detect chromosomal abnormalities early in the pregnancy so they can make educated decisions. For some women, these tests may result in the choice to terminate the pregnancy should an abnormality be detected. As a nurse, it is important to recognize any bias regarding the patient's decision making and remain non-judgmental and respectful to the patient during this difficult time. Other women may choose to undergo genetic testing to make necessary arrangements should the child be affected with the disorder. There are also emotional difficulties for the patient who has chosen to delay childbearing. The more mature patient may have had an imagined plan and picture of what pregnancy and parenthood should look like and may find it difficult to cope when things do not go exactly as planned. This new journey to motherhood may mean the patient has to give up or alter career plans. For the more accomplished patient, this may be a difficult and unexpected transition. Nurses should be prepared to address both the physical and emotional needs of a patient experiencing delayed childbirth. Although these patients may have some unique needs throughout their journey to motherhood, many go on to have healthy, enjoyable pregnancies. Facilitating expression of emotions. Several days or weeks may pass between performance of some diagnostic studies and receipt of results. This is a particularly difficult time for many expectant parents, and nurses often assist the couple to express their concerns and emotions. A broad statement, such as, "Many couples find it difficult to wait for the results," will often elicit free expression of the parent's feelings. Follow-up questions, such as, "What concerns you most?" may reveal anxiety about the procedure itself or about the possible effects of the procedure on the fetus. Simply acknowledging that it is a stressful time helps the couple cope with their emotions. Women who have undergone many tests and procedures for infertility may be especially anxious. Once pregnancy is achieved, they worry about their ability to carry the fetus to term and may see themselves as being at higher risk than they actually are. If they have had unsuccessful pregnancies in the past, the fear that the present pregnancy may also be lost makes it hard for them to be optimistic about success. Mature gravidas also worry about complications that may affect the fetus or their own health. They are aware that they may not have another opportunity for pregnancy because of their age. They may be concerned about their ability to balance their careers with increased family responsibilities. Providing parenting information. Nurses often help the mature mother prepare for effective parenting by pointing out her individual strengths and advantages. Anticipatory guidance about measures that will help conserve energy after childbirth is very useful. These include meal planning and setting realistic housekeeping goals. In addition, many older mothers need to mobilize all available support so they can reserve their energy for care of the infant. When giving suggestions about conserving energy and obtaining support, avoid using terms like elderly primipara when referring to the expectant mother. It is important not to make her feel abnormal because of her age. Unless she has complications, she should know that her prenatal course will be the same as that for any other pregnant woman. During the first weeks after childbirth, the mother may experience feelings of social isolation, particularly if her friends have children who are much older. She may miss the mental stimulation of a job while staying at home. If she elects to return to work, she is likely to experience guilt and grief because she must leave her infant. Balancing the needs of the infant and the challenges of a career or occupation may be difficult. Older mothers are likely to seek information they need from a variety of sources. They are particularly interested in learning how the infant grows and develops, and what they can do to provide nurturing care for the infant. Meeting other older expectant parents in classes may provide friendships that can continue after the birth and help women provide support for each other. Playgroups are another source of support where mothers can compare notes on parenting. Older parents may interview care providers before choosing one. They may have special concerns and ask many questions. They often adopt health-promoting activities such as improving nutrition and eliminating harmful substances. Printed materials that can be used to reinforce teaching are often helpful. Substance abuse. Chemical dependence is the physical and psychological dependence on a substance, such as alcohol, tobacco, or drugs, either legal or illicit. When present during pregnancy, it can pose serious risk to both the mother and infant. Incidence. Data have shown that approximately 5.9% of women use illicit drugs during pregnancy, 8.5% use alcohol, and 15.9% smoke cigarettes. Over the last decade, the number of women abusing prescription opiates and heroin increased dramatically, thus necessitating that increased attention and resources be spent on this significant issue that affects a vulnerable population. Maternal and fetal effects. When a pregnant woman uses a substance by drinking, smoking, snorting, or injecting it, the fetus experiences the same systemic effects as the expectant mother, but often more severely and for a longer time. Because the fetus is unable to metabolize drugs efficiently, a drug that causes intoxication in the woman causes it for prolonged periods in the fetus. Therefore, substances taken by the woman can have a great impact on the fetus and interfere with normal fetal development and health. Maternal, fetal, and neonatal effects of commonly abused substances are summarized in Table 11.2. Tobacco. Tobacco is one of the most common harmful substances used by women in pregnancy. Tobacco is very addictive and harmful to the developing fetus in several ways. Nicotine causes vasoconstriction and reduces placental blood circulation. Carbon monoxide inactivates fetal and maternal hemoglobin. This combination significantly reduces the amount of oxygen that goes to the baby. Maternal and fetal effects. Some maternal effects of cigarette smoking include decreased appetite, poor weight gain, and poor nutritional status. Neonatal effects. Neonatal effects include risk for low birth weight, increased risk of SIDS, and increased risk for colic, asthma, and childhood obesity. Alcohol. Alcohol is a teratogen known to have the potential to cause both mental delays and birth defects in the developing fetus. The amount and timing of alcohol ingested have a direct impact on the degree of impact to the fetus. Although alcohol intake during the first trimester appears to have the largest negative impact on cell growth and division, alcohol use during any point in the pregnancy can have harmful effects on the fetus. Studies have shown that compared with other harmful substances in pregnancy, alcohol causes the most significant harm and long-term impact. Maternal and fetal effects. The use of alcohol in pregnancy can increase the risk for miscarriage and the risk for preterm labor. Neonatal effects. Alcohol crosses the placenta and reaches the fetal liver. However, the fetal liver is unable to metabolize alcohol. The teratogenic impacts of alcohol can lead to fetal alcohol spectrum disorders, the most severe of which is fetal alcohol syndrome. Fetal alcohol syndrome is characterized by three distinct features: prenatal and postnatal growth restriction, central nervous system impairment, and an identifiable grouping of facial features. Growth restriction is evident in length, weight, and head circumference. CNS deficits include intellectual incapacities, learning disabilities, attention deficit disorder, and reduced short-term memory. Facial features frequently associated with fetal alcohol syndrome include microcephaly, short palpable fissures, the openings between the eyelids, epicanthal folds, flat midface with a low nasal bridge, indistinct philtrum, the groove between the nose and the upper lip, and a thin upper lip. Although not all infants exposed to alcohol during pregnancy will have signs or symptoms of fetal alcohol syndrome, it's important to educate patients that there is no safe level of alcohol during pregnancy. Marijuana. Recent studies have shown that as many as 10% of women have used marijuana during pregnancy. Maternal and fetal effects. Consumed in large doses, marijuana can cause anxiety, tachycardia, confusion, panic, and hallucinations. When consumed in small amounts, marijuana increases sympathetic nervous system stimulation and decreases parasympathetic stimulation, which in turn causes tachycardia and increased cardiac output. Neonatal effects. There is little definitive research to show the absolute impact of marijuana use to the fetus. However, preliminary studies show that marijuana use can lead to cognitive, behavioral, and emotional deficits in the infant, as well as memory and problem-solving issues. Cocaine. Cocaine is a powerful, short-acting CNS stimulant. It blocks the reuptake of the neurotransmitters norepinephrine and dopamine at the nerve terminals, producing a hyperarousal state that results in euphoria, sexual excitement, increased alertness, and a heightened sense of well-being. Physical effects of cocaine use are related to cardiovascular stimulation and vasoconstriction. Hypertension, tachycardia, arrhythmias, tremors, anemia, anorexia, and even death to both the mother and or fetus can occur. When the initial euphoria wears off, a period of irritability, exhaustion, lethargy, depression, and anxiety occurs. This state elicits a strong desire for additional cocaine so that the initial feelings can be recaptured. Maternal and fetal effects. Because many women who use cocaine also use other drugs such as alcohol, tranquilizers, heroin, or marijuana to come down from the hyperarousal state that cocaine produces, it is difficult to define the exact effects of cocaine on the fetus. Women who abuse cocaine are less likely to seek prenatal care or eat a diet that contains adequate nutrition. Sex may be exchanged for drugs, increasing the risk for STDs. Because of the vasoconstriction of placental vessels caused by cocaine use, placental abruption is a known risk. Cocaine also stimulates uterine contractions, resulting in increased incidence of spontaneous abortion, premature rupture of membranes, preterm labor, and precipitous delivery. Neonatal effects. Maternal cocaine use puts the infant at risk for preterm birth, preterm rupture of the membranes, intrauterine growth restriction, and low birth weight. Bath salts. A new class of drugs known as psychoactive bath salts have become increasingly popular in recent years, and like other illegal drugs, pose a significant threat to both mothers and babies. Bath salts are synthetic cathinones or methcathinones that come from the khat plant, K-H-A-T. Bath salts can come in their pure form or be mixed with other drugs and can be taken in pill form, smoked, or snorted. When ingested, bath salts induce feelings of euphoria, increased alertness, decreased need for sleep, hallucinations, agitation, and delusions. They have also been shown to cause tachycardia, hypertension, stroke, and acute myocardial infarction. Although little is known of their exact effect on pregnancy, the serious maternal impact can lead one to infer that they would be harmful to a developing fetus. There's also evidence that the khat plant increases blood pressure, gastric reflux, and constipation, which can all cause issues in pregnancy. Amphetamines and methamphetamines are CNS stimulants that, when taken, leave users with the feeling of immense pleasure. Maternal and fetal effects. Amphetamine and methamphetamine use in pregnancy causes increase in blood pressure and an increased risk for placental abruption. It also has the potential to cause impaired brain development, delayed motor development, and delayed white matter maturation in the developing fetus. Neonatal effects. Infants exposed to amphetamines or methamphetamines frequently exhibit signs of neonatal abstinence syndrome, such as poor feeding and sucking reflexes, jitteriness, irritability, and high-pitched cry.